Good afternoon. My name is Hannah Estrada, and today I will be presenting my Plan Change project as well as my nursing research project for both classes. The title of my project is Implementation of a Sleep Protocol for Acute Medical Surgical Adult Patients to Increase Patient Satisfaction, Mood, and Effective Discharge Teaching. My PCOT for this project is over a 3-month period. How does the implementation of a sleep protocol compared to usual care in adult patients admitted to acute medical surgical units affect the perceived quality of care and engagement in discharge teaching? And this is a significant problem because in healthcare, the ultimate aim is to ensure the well-being of patients, and one aspect often overlooked is their sleep. So despite the knowledge that sleep is a vital component for cognitive health and function, there remains a lack of policy, research, and implementation of sleep promotion in the acute medical surgical units. So although there is proven negative associations with healthcare outcomes, to date there's no specific studies that examine sleep in acute medical surgical patients, and often they are studying ICU patients. The connection between sleep and mental well-being should not be underestimated, especially with acute medical surgical patients who often are in a state of sleep deprivation because of the constant disturbances throughout the night by nurses, medical interns, and residents. Sleep problems have been reported in 22 to 61% of hospitalized adult patients, and cognition and mindset are a critical component when educating patients about their conditions and their care plans. Optimal cognitive function and a clear mind are prerequisites for effective patient education. Patients need to be in the best possible mental state to grasp and retain vital information that will form their recovery journey. This becomes even more pivotal when we consider that acute patients require education that will allow them to go home and not come back to the hospital. The databases utilized for this research were Google Scholar and PubMed. The keywords I used were sleep protocol, medical surgical sleep, patient satisfaction, and impact of sleep. I also made sure that all recent publications were within 10 years, and for relevancy, they were all written within the US healthcare system. As previously stated in the problem significance slide, majority of the sleep studies were done in ICU, as well as the sleep protocols are all done for the ICU unit. However, insights from these studies and their sleep protocols can then be applied to acute medical surgical units, such as a qualitative analysis conducted by Fiedler et al. Based on 45 articles highlighting that factors such as routine vital checks, care team interruptions, and medication administration significantly disrupt patients' sleep in hospitals, as well as environmental aspects such as light and noise contributed to these sleep disturbances. Despite these findings, a surprisingly 88% of sleep promoting interventions target patients using relaxation techniques rather than environmental aspects. Another study focuses on critically ill adults showed that implementing a sleep promotion bundle led to positive outcomes by addressing environmental factors such as light, noise, and temperature, along with emphasizing sleep hygiene and alternating the timing of care interventions. The study observed a reduction in delirium among ICU patients. Once again, this is a study that was done in ICU. However, it can be adapted for med-surg patients because they are also going through sleep deprivation. So we're wanting to create an environment that's more conducive to quality sleep. The intervention should be applied at a multiple level, including making unit-wide changes, coordinating patient care thoughtfully, and providing education to both patient and staff. This was written by the Minimizing Sleep Disruptions for Hospitalized Patients, a wake-up call with Gordon and Inouye in 2018. So these findings collectively emphasize the significance of designing interventions that consider both the patient practice as well as environmental elements to enhance patient sleep experiences. Lastly, I included an article on if patient satisfaction surveys are an appropriate tool for gauging the quality of care, and the article at the bottom left prove that patient satisfactory surveys are a good tool to gauge patient quality of care, as well as how their overall experience in the hospital is, including discharge teaching. For best practices, I use the 2018 Clinical Practice Guidelines for Management of Pain, Agitation, Delirium, Immobility, and Sleep. This is a sleep-promoting multi-component bundle that was implemented in ICUs. However, it is easily adaptable for acute med-surg floors, as well as the National Sleep Foundation guidelines, which emphasizes the significance of giving priority to sleep to enhance health in underrepresented communities. Here are some alternative solutions to my intended outcomes. So my research is looking at the patient satisfaction scores and how we can increase patient satisfaction, as well as how we can increase effective discharge teaching. And I found that sleep promotion and sleep protocols are one solution that will address both patient satisfaction as well as effective discharge teaching. But if I were to divide these two outcomes, I was able to find research on how to increase patient satisfaction. So one study looked at communication curriculum, and the purpose of this study was to identify the patient-doctor as well as patient-nurse communication areas, and if implementing a training program on how to effectively communicate at the bedside would increase patient satisfaction. And through this study by Allenbraugh, they found that by implementing a training for the nurses as well as doctors in their communication skills, that they were able to increase the patient satisfaction scores. The second study in patient satisfaction was done in the pediatric unit, and they are looking at the delays in call-out response and how that affected the patient's quality of care or their perceived quality of care. And they found that the delays in the call-out response affected the patient satisfaction scores, and if a nurse were to answer the call-out in a timely manner, that those patient satisfaction scores would increase then. The goal outcome of effective discharge teaching. One study looked at discharge teaching and how to evaluate its effectiveness by using this readiness for hospital discharge scale. They found that using this scale, they were able to evaluate if the patient being discharged was able to receive their teaching, as well as if the family wanted to be involved. And they found that in this study, using a scale was a good tool to identify when to implement the discharge teaching. However, all of these studies just highlight one of the outcomes versus sleep promotion protocol, which will then address both the patient satisfaction as well as discharge teaching. For my protocol, I used the literature that was on ICU sleep promotion bundles and adapted it for a more feasible checklist for a med-surg floor. So this protocol includes in the intervention categories such as sleep history, medication, the nighttime sleep components, and then environmental factors that we found was a huge effect on sleep in medical surgical floors. And so the first component is gathering information about the patient's sleep and bedtime routine. Not every patient is going to have the same sleep architecture, so it's important for the nurse to identify those changes and if a sleep promotion bundle will even be affected for those, as well as gathering information about any medical equipment that they might be using. Home medication review. So some medications do contribute to disrupted sleep and delirium. So just identifying if they're already on those medications and therefore a sleep bundle will not work for them. And then nighttime sleep, so minimizing routine assessments. This is a limitation of the study because we know that nurses want to assess our patients in a timely manner and make sure that they're okay. But one literature review found that it was okay and safe and feasible for a patient to be unassessed for about 4 to 6 hours during the nighttime so that they can get some sleep. And then limiting daytime naps and involving the family in supporting restful sleep environments. The last two involve the environmental factors, so very easily changed factors such as opening the blinds during the day and dimming or turning off the lights prior to going to sleep, and offering them eye masks if necessary, as well as noise, providing them earplugs, offering to turn off the television, and then minimizing the noise inside and outside of the patient's room, especially during the nighttime hours. This is a continuation of the protocol, so easily changeable temperature in the room, so adjusting the patient's sleep preferences, the patient positioning, so providing additional pillows if that helps them, discussing the goals and the sleep education with the interpersonal team, so through emails, signage, and in-person communication. And then pain management is a huge factor in patients not being able to sleep, so providing them with the medication that they need prior to the hours of sleep. So this is my implementation plan. Initial step starts with a FAIS assessment, which is a tool used to find factors affecting inpatient sleep. So FAIS, it is a questionnaire that helps identify the main contributing factors to sleep disruptions in medical surgical units. So once we use this tool, we can identify the main sleep disruptors to develop a protocol specific to each unit. So the protocol will look like what I had previously shown. And then after the protocol is developed, a 3-month pre-survey, patient satisfactory survey will be taken place to use as a comparison prior to implementing the protocol. Then after that 3-month initial pre-survey, then we will implement the sleep protocol for 3 months. And then the final stage will be post-surveys and evaluation, as well as comparison of the two groups. So these are some limitations or inhibitors to the plan change project. The first one is confounding variables towards patient satisfaction surveys. The goal of the study is to increase the patient's quality of care, perceived quality of care, using a sleep promotion bundle. However, there may be other reasons for a patient to give a low patient satisfaction score. And so having a good survey that addresses individual categories of care will help decrease this confounding variables. Medication scheduling is a huge topic in terms of patient interrupted sleep and timed medications. I can think of antibiotics as a specific medication that needs to be given at a therapeutic time. And so that's something that is difficult in the protocol to follow. However, environmental factors are still able to be changed to help the patient sleep better. Interdisciplinary coordination will be a huge limitation or inhibitor because especially with med-surg patients, there's many people that are coming to see the patient and they may not be aware of the policy, resulting in them accidentally disrupting the protocol. And then this is addressed in the protocols questionnaire or checklist is the patient's individual sleep architecture. Not every patient has the same sleep schedule and not every patient goes to sleep for a designated amount of hours. However, that's also addressed in the questionnaire and asking the patient what their preferred sleep nighttime routine is. Lastly is the evaluation component of the study. So to evaluate the outcomes, we will be using the standardized patient satisfaction tool that has been used across multiple studies and literature and has been found to be a great survey in gauging the patient's quality of care and perceived quality of care, as well as their understanding of discharge teaching. So once they fill out the surveys, we can then compare the two groups pre and post sleep protocol. And that is my plan change project. Thank you so much.